All right, it's 10:30. We'll just wait a couple more moments for folks to join, then we'll get started today.
I should just clarify about those two handouts. Should I direct people to a certain person to obtain them, or
Yep, me. Yep.
me to Julie? Okay.
Yep.
Very
They can
good.
email. I can email quickly.
Very good. Very
Yeah.
good.
Thank you. All right, Dr. Lewis, want to take it away and do our introduction, get started here this morning?
Wonderful. Welcome, everyone. I am very pleased to be introducing Dr. Liu for this important topic, important grand rounds on the cultural formulation in our DSM and how to best do one and the history of it, etc. This is designated a professional development workshop. So hopefully we have a lot of our faculty members here because we consider this a very important topic as well. Those who aren't here can stream it later. So Dr. Francis Liu is the Luke and Grace Kim Professor Emeritus in Cultural Psychiatry at the University of California at Davis. He's been an esteemed contributor in the area of cultural psychiatry, including the areas of religion and spirituality, diversity and inclusion, and health equity. He's been a committed and longstanding contributor to the medical and resident level, fellow level education in psychiatry, and gives regular talks and is regular attendance at workshops in for the national educational organizations in psychiatry, and I have seen him there on many occasions. Many of you might know Dr. Liu through his presentations at the APA annual meeting, where he has presented every year since 1984. The APA has awarded him special presidential commendations in both 2002 and 2016 for his contributions to cultural psychiatry. And in 2020, he was awarded a Distinguished Service Award. In 2020, the Society for the Study of Psychiatry and Culture awarded him the Lifetime Achievement Award. And in 2021, the American College of Psychiatrists awarded him its Distinguished Service Award. In addition, Dr. Liu has a deep interest in film and its interface with psychiatry. Since 1987, he's led or co-led 37 film seminars at the Esalen Institute in Big Sur, California, which is depicted on his virtual background. And the topic has been on positive psychological qualities and character virtues. Dr. Liu wants to share his slides. For anyone who wants them, they can contact Julie Dumas' email for a copy as well. He has a very thorough resource list that that we can email out to you as well. So Dr. Liu, thank you very much for virtually coming to Vermont to present this morning. Welcome.
Yes, thank you very much, Dr. Lewis. And I've known you. We've met each other so many times through the years, and really appreciate the invitation to present and share material with you all. coming from the DSM-5 TR that was just published on March 19th. So you're getting the latest information here that I hope will help you in your day-to-day work with patients. So I'll now share my screen. We will have a good 15 minutes for Q&A at the end. Please type in the chat your questions so we can efficiently handle them, and do so during the presentation as well. In the chat, I've already typed in my email address if you have any questions after today. Also, I've given you a link to the most important and meaningful article I've written in my life on Ikiru, my favorite film. So that's your bonus for today. So today I'll be speaking primarily about these two tools in the DSM-5 TR for culturally and structurally competent care. I have no disclosures. Again, please feel free to email me after today if any questions come up. So I wanted to speak about, at the very beginning here, what is cultural competence? Why is it important? Looking at quality of care issues, as well as training issues. I'm just going to focus on the ACGME accreditation standards for general psychiatry residency training programs. And then a word about this concept of structural competency. Then we will look a roadmap of where cultural and social structural issues appear in the TR, in the introduction, in section 2, and then section 3, where we find our two tools. So this is a definition from the Joint Commission that accredits healthcare organizations, the ability of healthcare providers, clinicians, as well as healthcare organizations, systems of care to understand and respond effectively. And there are two verbs there. Understand is one thing, but responding effectively is another, to the cultural and language needs. And language is stated explicitly for its obvious impact on communication, brought by the patient to the healthcare encounter. And here is my one slide elaboration of this. I see there are different elements to cultural competence, like different parts of the elephant, and that this is an ongoing journey, not an endpoint. And it begins with a self-assessment about one's own cultural identity, values, prejudices, and biases. Then the attitude and skills involved in cultural humility about the limits of one's assessment and treatment knowledge and skills. To be open, to be curious, to know that you don't know. That's so important, as opposed to assuming things. So the motto is ask, don't assume. Then valuing diversity, that it makes a difference in our assessment and treatment, as opposed to saying, well, we're all Americans, we treat all the patients the same. And ensuring safety about the power dynamics influenced by cultural differences. We already know that there is a power dynamic between the patient and the clinician. And finally, responsiveness to cultural diversity. That's by adapting our assessment and treatment. And that's what our tools will help us with. And that's kind of like the bottom line. How does this help us with our differential diagnosis and our treatment plan, which we do every day with every patient? So the idea is put on the cultural lens and see what more you can find. So this landmark report from the National Academy of Medicine, as it is now called, pointed to how we needed to improve the quality of our healthcare system. And they enunciated 6 quality outcomes as goals. And I want to just highlight 2 of them. One is patient-centered care that is respectful of and responsive to. So you can see again the 2 aspects. Respectful of is one thing, but responsive to individual patient preferences, needs, and values. So this is aligned with culturally and linguistically competent care. And then equitable care, providing care that does not vary in quality because of personal characteristics, such as those listed. Now, the key word here is quality. It doesn't say providing care that does not vary because of cultural identity variables. And I would argue that if you don't take these into consideration, you won't be providing quality care. And this is aligned with the concept of reducing or eliminating disparities. The Surgeon General back in 2001 also issued a report that documented for the very first time that ethnic minorities receive poor quality mental health care. And since that time, the federal government has issued many reports looking at health and mental health disparities, not only as related to race, ethnicity, but also other cultural identity variables. Now, moving on to the training standards for residency training, there, as you all know, 6 core competencies, and I'm just going to mention a few of these and how it relates to this topic. First, under the core competency of patient care, they start with a little background and intent statement where they cite the report that I just mentioned. And they say as a subcompetency that residents must demonstrate competence in the evaluation and treatment of patients from diverse backgrounds. Now, what might be related to that? Well, we have this subcompetency that residents must demonstrate a competence in forging a therapeutic alliance with such patients. Now, what might be related to that? Then under the core competency of medical knowledge, we have that residents must demonstrate knowledge of the cultural elements of the relationship between the resident and the patient, including the dynamics of differences in cultural identity, values, preferences, and power. So this is very much aligned with the 4th part of the outline for cultural formulation that I'll be speaking about in just a moment. Then for professionalism, the core competency of professionalism, we have again sensitivity and responsiveness to a diverse patient population broadly defined. And finally, for the core competency of systems-based practice, we have that residents must demonstrate awareness of and responsiveness to the larger context and system of healthcare, including the social determinants of health, as well as the ability to call effectively on other resources to provide optimal health care. Now, this is very much aligned with the concept of structural competency, which the psychiatrists Jonathan Metzl at Vanderbilt and Helena Hansen now at UCLA coined in 2014. And here's a quote from 2018 that structural competency encourages clinicians to recognize how social, economic, and political conditions produce health inequalities in the first place. And it calls upon us to recognize how these social structures shape symptoms and diseases and mobilize us to correct these inequalities, both in the physician-patient interaction, in the clinical situation, and beyond the clinic walls. That means social action. And so I'll come back to this when I speak about the social determinants of mental health. So now looking at the roadmap here in the TR, we have the introduction, and the section in the introduction that was cultural issues has now been renamed cultural and social structural issues. So you see, bringing those two together. And then the section, again, what's in yellow is added, what's underlined are the take-home points. We have cultural concepts of distress, and these three subtypes are defined here in the introduction. They're further elaborated on in the cultural concepts of distress section in section 3. The idioms of distress are like the presenting complaints. Then we have the explanation or cause or explanatory model. And finally, the syndrome, which is a clustering of idioms and explanations and other features. I'll come back to this in a moment. Then we have this new section, and very important one, called the impact of racism and discrimination on psychiatric diagnosis, and how this was attended to in the TR. And the section entitled Gender Differences is now labeled Sex and Gender Differences. Yes, I should say that in the process of the TR, as well as in the process of for the 5, there was a cultural issues work group and a gender issues work group that worked on specific portions here. But in that section on the impact of racism and discrimination on psychiatric diagnosis, we find these very important statements, such as race is a social, not a biological construct, and the term racialization is used because racialized identities are important because they are strongly associated with systems of discrimination, marginalization, and social exclusion. And we'll be coming back to those. And then a very important paragraph in that section says that racism exists at different levels. We often think about racism as a personal or interpersonal phenomenon, because it's perhaps more immediate, but there's also systemic and institutional as well as social structural levels. So, for example, the APA from years 2020 to 2021 had a task force on the structural racism throughout psychiatry to take a look at that. And racism is an important social determinant of health. This idea of racism as a public mental health crisis has been enunciated by the AMA and the AAMC and other organizations. And so therefore, the bottom line is that clinicians should make an active effort to recognize and address all forms of racism, bias, and stereotyping in our assessment. So again, I know this is a tall order, how do you do this? Well, we'll get to that when we look at our tools. So throughout the TR, this has been the result that the term racialized is used rather than racial, ethno-racial as opposed to ethnicity or race. Latinx is used, Caucasian is not used, and the terms minority and non-white are also avoided. And even this notion of culture has been put aside for things like cultural context or cultural background for this reason. Now, turning to the section 2, where we find the narrative descriptions of our disorders and the diagnostic codes and criteria. In the narrative sections, for some of the disorders, we find these culture-related diagnostic issues sections, as well as the sex and gender-related diagnostic issues sections. And also at the back, there are a group of conditions called other conditions that may be a focus of clinical attention. Now, these have been relabeled Z codes instead of V codes to align with ICD-10. So indeed, when they say text revision, they mean 3/4 of the narrative texts have had significant revisions, including the 2 sections that I mentioned. And so the latest references are here, and it's really up-to-date information concerning things like variation in symptom expression, attribution, causes, and the factors associated with differential prevalence. You'll notice that reference to American Indians or Native Americans in these sections is rather sparse, and the reason being that research, unfortunately, have often had insufficient numbers of American Indians or Native Americans to make statistically sound conclusions, even though there may be a few in the studies. So therefore, the decision was made not to include that data, and that's why they don't appear very often. Also, cultural norms that may affect the level of perceived pathology and attention to risk of misdiagnosis, such as the overdiagnosis of schizophrenia in African Americans. Now, turning to the Z codes, this is the introduction to it. As you can see, these are conditions or problems that may affect the diagnosis, course, prognosis, or treatment of a mental disorder. And the reasons why you may include this in the diagnosis may be coded. You can see in the 3 and 4 were added. If it plays a role in the initiation or exacerbation of a mental disorder, or if it constitutes a problem that should be on the management plan. But it's important to remember that these are not mental disorders. So that's why these tend to be kind of forgotten, because if our job as psychiatrists is to diagnose mental disorders, and these are not mental disorders and often not reimbursed, unfortunately, although that's beginning to change, then why should we even pay attention to them? But I'll get to that in just a moment. And so these are categories of these conditions. Suicidal behavior, non-suicidal self-injury was added. But for these others, within these categories, there are specific codes for specifics, and I'll give you some examples in just a moment. And here are more sections. Now, jumping ahead to this next slide from Michael Compton and Ruth Shem from 2019, they speak about the social determinants of mental health there in the center. Now, the 10 in yellow, they wrote about in their 2015 book with that title, and the 6 in white are new ones. So look in the lower left corner, we have adverse early life experiences, the ACEs, ACES, which we've known for over 20 years is a social determinant of mental health. And to the right, we have discrimination, social exclusion, social isolation. And looking above that, we have things like homelessness, food insecurity, and unemployment. Things that have all gotten worse in the last few years with the pandemic. And then in the upper right, we have climate change as one of the new ones that they've added. So the big picture here is we have biomedical determinants of mental health and psychological determinants of mental health. And yes, we have social determinants of mental health, which, as you can see, can lead to adverse health and mental health outcomes. downstream. Now, upstream from those social determinants of mental health are the underlying public policies and social norms related to the concept of justice that impact on those social determinants of mental health. So the American Psychiatric Press has actually published like a trilogy here, which I highly recommend. You have the original book on the social determinants of mental health, and the 2021 on justice and injustice, and a new one that just came out in this past month about 7 federal legislation policies that impact on the social determinants of mental health. So a recent example, it's not in the book, is the child tax credit, which last year cut childhood poverty by 50%. So you can see how that piece of federal legislation had a tremendous, that public policy had a tremendous impact on that social determinant of mental health. So that's that social action piece that I was referencing earlier. So these are specific codes under this category. And again, for this category, and for ones related to the social environment, we have this one, for example. The language is the same as the 5, bullying, teasing, targets of verbal abuse and humiliation. And we have this one on acculturation difficulty, adjusting to a new culture. So again, you can diagnose a mental disorder and you could diagnose acculturation difficulty or any of these as well. And then this one, target of perceived adverse discrimination or persecution, broadly defined. And again, perhaps some of your patients have come in, with this kind of complaint. So instead of saying, well, this doesn't quite fit any of the diagnostic criteria, it's really not that important, I would say that it very well may be important as the patient's presenting complaint that needs to be addressed, and perhaps put on the diagnosis if it's significant. And then under this category, we have exposure to disaster, war, or other hostilities. So we have to look no further than Ukraine to give a very tragic and visible example of that. And then finally, this category, which I helped to get into the DSM-4 in 1994, these are distressing experiences related to loss or questioning of faith, or someone having a mystical experience or a near-death experience, and they're distressed about it. This should not be seen as a symptom of a mental disorder, but as a religious or spiritual problem. So now moving on to section 3, here is where we find our 2 tools. The outline for cultural formulation first appeared in Appendix I, the 9th appendix in the DSM-4 in 1994. It was revised for the 5 and revised for the TR. The cultural formulation interview, new in the 5, unchanged in the TR. And then a section entitled Cultural Concepts of Distress, which goes into further elaboration and discussion about that, and now has 10 examples up from 9. So here is the outline, and I'll be speaking about this in greater detail in just a moment. There are 5 sections. The first 4 sections are interrelated fields of information that we ask the clinician to gather. What are the cultural issues in this case? Well, here's a good place to start. Now, treatment team and institution was added to D. Again, I think to broaden that relationship issue. And then the last part, the overall cultural assessment, it calls for us to summarize the information. And how does this then impact on our differential diagnosis and treatment plan? Now, the work group on cultural issues for the 5, headed by Roberto Luis Fernandez at Columbia, and I was part of that 30-person work group, felt that to help the clinician operationalize the outline, it would help to provide questions that they could ask the patients and informants to gather the information for the outline. So we have printed in the 5 and the TR, the actual patient and informant versions of 16 and 17 questions. They're identical except for an added question for the informant version. And then very importantly, and this is in the handout, these 12 supplementary modules that you can access by that website there that give you deeper dives into sections of the outline. So for example, there are 3 questions about cultural identity in the core CFI. If you wanted to ask more questions, you pull out this supplementary module where there are 28 additional questions. Now, on the right-hand column, the last 4 supplementary modules are around specific patient populations or issues. So if you're working with children and adolescents, older adults, patients involved with religion or spirituality, or immigrants and refugees, I highly advise that you access those supplementary modules to guide you in your work here. So this is what the beginning of the CFI looks like in the TR. And as you can see, it's not simply a list of 16 questions, but we have in the left-hand column a guide to the interviewer, the right-hand column instructions, and so on. So the first question is, what brings you here today? So hopefully you're asking that already. You're already doing one of 16. So now I'm going to go over the 16 questions of the CFI, the core CFI, in the order they appear and relate them back to the outline. Now, they're not in the same order because we felt the logical place to start is what brings you here today, rather than what is most important about your identity or background. So what brings you here today? The patient might say wind illness. Well, sometimes people have different ways of describing their problem to their social network. How would you describe your wind illness to them? So wherever you see problem in caps and brackets, please try to use the patient's words. And what troubles you most about your wind illness? Next 2 questions are about cause. Why do you think this is happening to you? And what do you think are the causes of your wind illness? And what do others in your social network say are the causes of your wind illness? So these first 5 questions refer to the part B, the cultural concepts of distress, which is defined here in section 3, and all of this material is in the handout. As you can see, the 3 subtypes are mentioned that are defined in section 1, and the level of severity and meaning of these distressing experiences should be assessed in relation to the norms of the individual's cultural background. So that's why we have those 2 questions about the social network. So again, what's underlined as a take home in yellow was added to give more details about this. And then the last sentence is the assessment of coping and help-seeking patterns should consider professional as well as traditional alternative or complementary sources of care. So here we're interested not only in visits to the psychiatrist or the social worker, but also Tai Chi and acupuncture and herbal medicine and spiritual healers. Now, the CFI questions that relate to this section are questions 11 to 15. So they will come a little later. We'll come back to this. And then, as I mentioned, there is the section in section 3 called Cultural Concepts of Distress, where you can read more about this idea. And there are 10 examples that are described in about a half a page each. Hikikomori was added. And so here is a little table in the far left. You see the names of these actual 10 concepts that are in the book, and in the center, which of the 3 subtypes, and in the far right, where in the world this has been reported. And of course, patients come from all over, the world to the US. So we are interested in this. And nervios in the middle there, as you see, is an idiom of a distress, but it is also part of the ataque de nervios, the cultural syndrome. So those two are related to each other. And there's not a one-to-one like connection, like nervios is just simply part of, an anxiety disorder. There's not that one-to-one connection. You can see nervios across many DSM diagnoses, and that's why it's important to understand the details on this. Now, this is the cautionary tale about why this is important for us to pay attention to. This is a book that provides a true life story of a Hmong infant, Hmong being an ethnic group from Laos, who had a grand mal seizure disorder as diagnosed by a neurologist and pediatrician in the Central Valley of California. And they had a biomedical explanation and a biomedical treatment of medications. However, the family called it "the spirit catches you and you fall down." And they had a supernatural cause to this phenomenon and a treatment pathway of using shamans. So unfortunately, there was never a recognition of this difference or a negotiation of these explanatory models and treatment pathways, and it led to non-compliance with the medication. The infant had a prolonged grand mal seizure and lapsed into a vegetative state and died 12 years later. So moving to our next two CFI questions, very important ones. Are there any kinds of support that make your wind illness better? And are there any kinds of stresses that make your wind illness worse? So these two questions relate to part C, and this is what we find in the TR. The first sentence really summarizes it all. Identify the key stressors, challenges, and supports in the individual social environment, which may include both local and distant events. Then this new sentence was added that's absolutely critical and ties in with the Z codes that I talked about earlier. These include the social determinants of an individual's mental health. And as you can see there, they really link in with what I discussed earlier. And then this third sentence is also important to provide us domains to think about, to assess the role of religion, family, and other social networks that could either cause stress or provide support. So religion and family is original to the 4. Other social networks was added in the 5. And this further elaboration you can see here for the TR, in that these domains could either cause stress or provide support. I mean, that's pretty obvious, but it's important to be explicit about that. So let me just amplify on this a little bit. So when we think about the interpersonal relationships as an example of the local social environment, it's happening like here and now, across those 3 domains, and pay attention to the Z codes and the social determinants of mental health, which could either be local by geography or time or distant by geography or time. So let me give you a few examples. One is AAPI hate, which has been increasing in the last few years in our country, as well documented by the website Stop AAPI Hate. So that's happening locally by geography or time. Certainly here, even in San Francisco, it's been on the rise. And throughout the country. But also it's distant by time because the Chinese Exclusion Act of 1882, the Japanese internment, as just two prominent examples. This goes back long in our history. And then climate change. That's happening here and now. The warming and the wildfires and the hurricanes, it's happening here and now. It's local by geography or time, but also distant because it's affecting the whole earth. And this has gone back to the Industrial Revolution beginning. So whenever religion or spirituality comes up, I would recommend taking a look at that supplementary modules where there are questions along these categories to further understand the role of religion or spirituality. And then family, of course, to use a genogram, think of beyond the nuclear family to the extended family, and how does this family might be understood through cultural identity variables such as those listed. And then Pamela Hayes, in her book that I will reference in just a moment, talks about culture-related strengths and support. So again, put on the cultural lens, see what more you can see about what's important to this particular patient that might make a difference. And so if she provides this list of things for us to think about. And here's another listing. So extended families or religious communities or involvement in a political or social action group may be important to the particular patient you're working with. And here are more. So things like caring for animals. So here are the key books. Again, the Social Determinant of Mental Health book, the Pamela Hayes book, which just came out in its 4th edition in January. I highly recommend that book. And then Monica McGoldrick's book, which has 52 chapters, not only on Vietnamese families and Japanese families, but also Italian families and Irish families. So the next 3 questions are on cultural identity, and it starts with, for you, what are the most important aspects of your background and identity? Are there any aspects of your background identity that make a difference to your wind illness? And then a second pass question, are there any aspects of your background or identity that are causing other concerns or difficulties for you? So this relates back to part A, the cultural identity. This is what we find in the 4. As you can see, a reference to race, ethnicity, and for immigrants and racial ethnic minorities, the biculturality, degree of involvement with culture of origin or the host culture, American culture, and then language. Added in the 5 was this very important sentence, which explicitly acknowledged additional cultural identity variables. And in the TR, this has been further elaborated on, increasing the number of variables and including the phrase among others to indicate that this is not a final and complete list. And then a very important sentence, note which aspects of identity are prioritized by the individual and how they interact or intersectionality. Those are extremely important concepts. So you can never tell somebody's cultural identity just by looking at them. You do ultimately need to ask, not assume. So let me give you 2 schemas to help you put your hands around this. This is the further description of this. This is all in the handout material. This is basically the same as was in the 5 about the biculturality and language. So we have the addressing framework, where the word addressing is an acronym to remind us of several cultural identity variables to pay attention to. However, it's not complete because, as you can see in the word language, there's no L in addressing, and yet that's an obviously important cultural identity variable. This comes again from Pamela Hayes' book that And then this schema where you can see linguistic characteristics at 8 o'clock, moving clockwise to 5 o'clock spirituality, the different cultural identity variables and how they intersect. And in this diagram at 6 o'clock, we have health, beliefs, and practices, which is part B, and environment, which is part C of the outline. I highly recommend this website to you for an e-learning program as well. So again, ask, don't assume. Asian is just a broad umbrella term. National origin doesn't define a homogeneous ethnic group. We have to ask. Cultural identity is related to all of the other parts of the outline. It's really quite important. And we ask that second pass question because sometimes we will find, or the patient will describe for example, an intrapsychic cultural identity conflict. So for the Vietnamese adolescent born in America who only speaks English, he might be asking, how much am I Vietnamese? How much am I an American? Or a person might be questioning, am I gay or am I straight? And the religiously committed person early in life who is drifting away from religion now might be conflicted about that. And then there can be interpersonal relationship conflicts related to different cultural identities. So that Vietnamese adolescent may have conflicts with his traditionally acculturated Vietnamese parents who only speak Vietnamese. So even though they share the same ethnicity of Vietnamese, they have different cultural identities and values, and conflicts can happen, and certainly at the social level. So questions 11 to 15 relate to coming back to self-coping, past help seeking, and barriers to care. And then the two take-home questions: what kinds of help do you think would be most useful to you at this time for your windows? And are there any kinds of help that your social network would suggest? So this brings us back to that part B that I said we would come back to later. And of course, patients may go to primary care first, or seek complementary alternative medicine, or a religious or spiritual healer. And just depictions of these and lists of these phenomena. And then the last question is one of the most important, and it just touches on the clinician-patient relationship. Sometimes doctors and patients misunderstand each other because they come from different backgrounds or have different expectations. Have you been concerned about this? And is there anything we can do to provide you with the care that you need? Again, this is one of the most important questions. So this relates to part D of the cultural features of the relationship. Again, treatment team and institution was added. The first sentence really says it all: identify the differences in the cultural identity between the individual and the clinician that may cause difficulties in communication and may influence diagnosis and treatment. Again, added in yellow was more elaboration on this. And then this was retained from the 5, that experiences of racism and discrimination in the larger society may impede trust. And this may lead to problems eliciting symptoms, misunderstanding what's cultural and what's psychopathological, and ultimately impact on the therapeutic relationship. So you see the alignment back to the ACGME accreditation standards. So let me give you 4 steps of how to implement this and 4 examples. The first step is to understand your own cultural identity through self-reflection. Know yourself basically in this area. Then compare the cultural identity of the patient to that of the clinician. So you could draw a little table in the left-hand column, the cultural identity variables like age, race, ethnicity, gender, sexual orientation. religion, spirituality. In the center, you put the patient's cultural identity variables, and in the far right column, you put the clinician cultural identity variables, and you look at the similarities and differences and how that might affect the therapeutic relationship. And again, these are elements of the therapeutic relationship we are concerned about, again, every day with every patient. And so the idea is put on the cultural lens and see to what extent these cultural identity similarities or differences may affect the relationship. And one aspect of this that we are concerned about, of course, is bias, either conscious explicit bias or unintended implicit bias. And so this can go both ways, the bias that the clinician has of the patient or the patient bias against the clinician. And there are many, different cultural identity variables that can be at play here. And even our profession has not been immune to this. As we all know, homosexuality was a mental disorder in the DSM until 1973. And the bias against religion and spirituality pervaded much of the last century. And the fourth step, and this is the responsiveness aspect, this is the take-home piece. What kinds of help, what would help the clinician to provide optimal care? Sometimes it's cultural identity matches. My first two examples will show that. Other times it's increased knowledge and skills concerning these areas through a cultural consultation, for example, with a faculty member, staff, or trainee who may know more about that particular culture, or a culture broker or a trained interpreter may have information, or a chaplain, or a faith leader or community leader. Or PubMed books, many books. At the end of my resource list on second handout, there's Amazon book lists to different topics in cultural psychiatry. And so now let me give you 4 examples. And I am watching the clock here, I'm aware of that. The first example is that my parents came from China in the late 40s, so I am Chinese. I was born in San Francisco. I only speak English. On an inpatient unit, a Chinese patient walks up to me and starts speaking Cantonese. So we have a language difference, and it's causing a problem in communication, and I need to respond by getting a trained interpreter or working through a clinician who speaks Cantonese, or referring the patient to a Cantonese-speaking psychiatrist. I'm a man in an outpatient clinic, and I'm interviewing a woman for the first intake interview, and the patient seems reluctant to provide much information. And at the end of the interview says, well, I'd rather speak with a woman psychiatrist. So what do I do with that? Do I write in the chart, well, treatment resistant, passive aggressive? Do I go down that psychopathology track? Or do I ask, don't assume, can you tell me more? And she says at the end, I don't want to get into it. I had a difficult time with my husband. And we later find out there's a very extensive sexual abuse history, and she has difficulty trusting men. So in that case, having a cultural identity match between the provider and the patient might make a critical difference. A third example, I'm a Biden Democrat, and a man walks in for the intake and is wearing a red cap that says, "Make America Great Again." And he looks at me and he says, well, what country are you from? So here we have a political orientation difference, and it's immediately, causing problems in our relationship. And I need to step back and understand what's happening here rather than kind of take this personally. And the last example is I'm an atheist, and I ask my patient, well, what brings you here today? The patient says, well, I've lost my faith in God. God is punishing me for my sins. So again, what do I do with this? Do I stay silent because I don't believe in God and religion doesn't belong in our discussions here, and I feel uncomfortable? But the patient may feel disrespected and drop out of treatment. Or worse yet, do I say things like, well, why is God so important to you? Kind of implying that there's something wrong with her complaints, kind of psychopathologizing those complaints, or again, may lead to the patient feel disrespected and drop out of treatment. So these are just some examples to illustrate this section. And what I've spoken about here today are simply about the patients and the clinician, but this concept actually applies across other relationships, as you can see listed, including the one that the TR now includes, the relationship between the patients and the treatment team and the institution. So the last part of the outline asks us to summarize all of this information and how does this impact on our differential diagnosis of mental disorders? You know, is it schizophrenia? Is it bipolar with psychotic features? Is it schizoaffective disorder? And other clinically relevant issues or problems. Now, those include those Z codes, as well as how does this impact on our treatment plan? So we're always interested in making an accurate and complete diagnosis. That's why it's important to have a differential diagnosis, because misdiagnosis can lead to mistreatment for the reasons that we've discussed here today. So again, I think that our two tools will help us to gather that information, and then also to look, we should look at those culture-related and sex and gender-related diagnostic issues sections, because they do give us information for a differential diagnosis at the phenomenon level as well as the disorder level. So hearing voices, you know, are there cultural or religious situations or backgrounds where that is not seen as psychopathology, as an auditory hallucination, psychotic symptom, but rather a cultural or religious phenomenon? And at the disorder level, you know, again, the overdiagnosis of schizophrenia in African Americans. And then also to review and add the Z codes so we can attend to them in the treatment plan. In terms of treatment plan, we have the process of negotiating and managing a treatment plan to maximize adherence and compliance. You know, are the patients taking their medication? That's perhaps one of the most often asked questions. So the idea here is put on the cultural lens and see if there may be cultural issues at play that might relate to that. And then examples at the content level, we have pharmacodynamics and kinetics may vary due to race, ethnicity, but only as part of the bigger explanation. Gender and age play a role, as well as environment. Looking at psychotherapy, my deceased colleague in Asian mental health used to say, when treating traditionally acculturated Chinese patients, be the tiger balm oil at the first interview, meaning that those patients expect some kind of small relief. And if it's not provided, the patients feel disappointed, may drop out of treatment. And look and see whether certain patients may need family assessment and family intervention that might be particularly important. And even in our usual modes of psychotherapy that are listed, supportive CBT and insight-oriented, what are the cultural modifications in therapy that would be helpful? There are books now on culturally responsive CBT, articles, and ultimately what therapist characteristics would facilitate or hinder treatment, as I talked about earlier. And when we look at sociocultural, go back to those three domains and address the social determinants through structural competency. Now, books for further learning, the TR itself, the clinical manual of cultural psychiatry, the best book on the OCF, that's an API book, as well as the handbook on the CFI, another API book. And then this is the best online training that is about an hour to an hour and a half that you can take. I highly recommend that. They have wonderful interviews with live patients. Here is another e-learning program on cultural competency. And then there is a Society for the Study of Psychiatry and Culture. We'll be having our annual meeting in San Diego at the end of April. A journal, the resource list, which is the second handout available, and finally a website, structuralcompetency.org, where you can learn more about that concept. So we have 15 minutes now to take questions, and so I'll stop sharing. So Judith or Julie, you can begin the questions.
First, I'll just thank you for a wonderful, broad and comprehensive presentation on this topic. And I think it reminds all of us to dive into some of the resources that you have provided. They seem very rich, as did your talk today. I'm going to be monitoring the chat for questions, and I think Julie's going to handle the hands up. So you can use your icon to raise your hand, or you can put something in the chat, and we'll sort of tag team the questions for Dr. Liu. I mean, I could start with a small couple of questions. I had two very specific questions for you, Dr. Liu. One is your example of the cultural phenomenon that you put into the problem. Is that an actual chief complaint of a patient? And if there's background to that, let us know. Also, just if the Z code is the only code that a patient qualifies for, is that billable through all insurances?
Yeah, so the problem, the whole focus of the CFI, I mean, the starting point, if you will, is to address the problem that the patient brings. You know, what brings you here today, the problem the patient brings, and to try to that's the starting point. And that's why we have it's so focused on the problem. But in the cultural identity section, we have that second pass question to see if there's anything else related to cultural identity that may be troubling them. And then in terms of the Z codes, reimbursement is generally not available, but that is beginning to change. The federal government is looking at this, and I think insurance companies are beginning to look at this. The APA Presidential Task Force on Social Determinants of Mental Health looked at this, and again, there are beginnings to change, because I think we're beginning to realize that unless we address these social determinants of mental health, we're not going to, we're really not going to be able to move the needle very much. And so at some point, people are going to recognize that it's cost effective. There's a business case for addressing the social determinants of mental health.
Okay, thanks. I see a couple of hands up. Dr. Emmons, you want to go first?
Can you hear me?
Yep.
Okay,
Yep.
great. Yeah, thank you for the presentation. I'm a psychiatrist who practices as a family therapist, so I find the focus on cultural competence, I welcome it, and I find it very exciting. It does take up bandwidth, and it's really interesting, but it takes time. If my standard interview is 90 minutes and I add a half hour to ask these questions and put things into a report, I can't see as many new patients. So do you have any suggestions for parts of our standard interview that are outdated and ought to be deleted so we can free up our bandwidth for new interesting things?
Yes, that's a very practical and important question. first of all, the use of the CFI in the DSM is recommended, in the first interview and so on. But again, that's kind of an optimal gold standard situation, or more aspirational, I would say. I think we need to take into context, of course, the clinical situation. So if you're in the emergency room, that may be a situation where danger to others, danger to self, or most important, versus, the first session of a insight-oriented psychotherapy process. Secondly, is you may only have time to ask a few questions. So people ask me, which are the priority questions? So if you'll just jot down the numbers now, I'll tell you which I think are like the priority questions. So 1, what brings you here today? 4, what is causing the problem? 6 and 7, what are the stresses and supports? 8, what's important about your background or identity? 14, what kinds of help do you think would you need now? And 16, which is about the clinician-patient relationship. Yeah, I think if I had to boil down the questions to the more important ones, those would be the numbers again: 1, 4, 6, 7, 8, 14, and 16. You do the best you can. That's all I can say. I mean, studies have shown that it does take indeed about 25 minutes to ask these questions once you've done this and know about this. But I think it's yet important to understand the whole framework, to know what's on the radar screen, because you'll never know when one of these things may be particularly important. And family is really important, as it was already in the 4, as part of section C, and has remained. And a number of cultural psychiatrists have focused on the family. And one of my Amazon book lists, which you can access by links at the end of the second handout, is on children, adolescents, and their families. So the whole issue of family is a part of this cultural assessment.
All right, Andy?
Thank you. This has been such an informative presentation and very practical, and you've shared so many important things that it makes me really excited to read your article on Kurosawa, since you said it was your most important writing. I wanted to ask a question that's pretty similar to what Bob brought up. I think a kind of variation on that theme. I was thinking about the different settings in which we work, and the systemic pressures, not only for time pressure, but also kind of turnover of clinicians, providers, teams, going from partial hospitalization, IOPs, inpatient units, outpatient settings, et cetera. And that even within each of those settings, there can be turnover weekdays, weekends, week to week. And at our academic institutions, we have a lot of trainee turnover during rotations and graduations. And so it seems that it happens, it's easy to provide culturally unresponsive care. I think it happens a lot. And so I was thinking a little bit about the repair process, and that many times it's difficult to do it within the sort of somewhat idealized frame of like what seemed like a more outpatient longitudinal, I'm meeting with this patient for multiple sessions, and so we can devote some time to this. That sometimes the lack of cultural competence occurs, and then a family or patient might say, could we work with one of the other doctors, or could we, and there isn't a way. And also, so I wanted to draw on that, like how do we sort of manage that, even if the dyad or interaction is not sort of able to be put back together to repair? And like, is there another cultural broker who could help? as well as I lost track of my second point. Well, maybe I'll
Well,
just leave it there.
I think the important part of your question is that you're searching, you're asking, you're aware of this possibility. Again, that you're illustrating cultural humility by this, by your line of questioning. That's halfway there. That you're at least asking the question, you're searching for the answers, or what might be optimal ways of dealing with this, as opposed to saying, again, characterizing, the doctor knows best. I have the answers, that you're open to discussion with the patient, and understanding the patient's point of view. I mean, that's a fundamental perspective that is really critical to culturally and structurally competent care.
I guess if I may, I did remember the second part, and I appreciate your response, was around the somewhat inherent power differentials in the doctor-patient relationship many times, and are there ways to help when a patient may feel like sharing their cultural experience or experience of being culturally mistreated would jeopardize their access to a needed provider, and we are in pretty short supply these days?
Well, I think to empathize with the patient's past pain or difficulties, and what can we learn from those experiences so that we don't repeat that. I think, to ask that question of the patient and see if the patient has suggestions on how to proceed differently.
And we still have a few minutes if the folks would like to unmute or put your video on or type something in the chat.
I know I've given an enormous amount of information. It is overwhelming. That's why I have provided 2 handouts. The first one actually is about 100 pages. Again, it has my slides. It has excerpts from the TR. It has articles. And it also has all of the 12 supplementary modules. And then the second handout is about 49 pages, and it's all about DEIA resources, including my Amazon book lists at the very end, which will lead you to book lists on like children, adolescents and their families, and cultural psychiatry.
So send me an email if you'd like to get a copy of those things.
In fact, the first list is the top 40 books in cultural psychiatry. So, including many that I've mentioned here in my presentation.
I'll just pick up on what Andy was asking about. It seems to me that when a patient asks to switch, the biggest important part of that is to ask about why and how and past experiences. And when you go through that, the switch might not be necessary if it's even available. So it's like almost a signifier from a patient to have that discussion. Maybe it's an actual request to switch, but it also is opening up that area that maybe had been neglected before. So, I like the Dr. Liu's response to that. It makes sense. And yeah. Questions? Anything else in the chat event? We have a thank you. Thank you for this invaluable presentation and access to your resources. Much appreciated from our Dr. Marin. I think we can.
And I've typed in my email address once again. If you have any other questions, please email me. I'm happy to respond. Happy to help out anytime. And the ADPERT annual meeting information just came out this week, and it's a very exciting lineup of plenary speakers and workshops. And the email that just came out today said it was record breaking in terms of registration.
Yeah.
So it's, I think that our field is paying attention to these issues very seriously, and it's very heartwarming to see the development over the years.
Yeah. If anyone is interested in what attending the training directors meeting is like, it's in San Diego in March. But I've always felt when I attend it that a wider group of people coming from our department would be terrific, as we're all involved in resident education, and absolutely all the workshops are highly relevant, and there are some amazing plenary speakers, including my good friend from New York, who was one of the surprise announcements. So I emailed her and connected. It's so yeah, just an incredible group of people coming. All right, so I guess not seeing any hands up or other questions in the chat will end. We want to extend our big thanks to Dr. Liu for this presentation. I think we're going to get a lot of emails requesting the slides and the resources. So we will get those out to people. Thank you so much.
Thank you, Dr. Liu. Sorry about the Zoom applause, but lots of appreciation from the audience.
No problem. Julie, I'll be sending you a new handout in just a moment.
Sure.
Okay, I'll send it to you in just a moment.
Great. Thank you very much.
Thank you.
All righty.